who we'll introduce in a moment. I just wanted to say a few words about Michael Davidson, who we are honoring today with this lectureship and visiting professorship. You know, for those who don't know, Michael was tragically gunned down at the Brigham and Women's Hospital on January 20th, 2015. I think it, you know, was tragic in any circumstance, but even more so because of the type of human being and person he was. And I was very fortunate to know Michael, and I'll share with you just some reflections on that from my own personal experience. I do want to recognize that there may be members of Michael's class of 2016, I put 1996 here, I'm sorry, 2006, you know, in the audience, as well as his father, Dr. Robert Davidson, and members of his family who might either be listening in on Zoom or watch this afterwards. So just a few words about Dr. Davidson. Michael was born in 1970 and grew up in Southern California. He was actually born at Duke University Hospital, where his father was training as a cardiology fellow at the time. But lived most of his young life in Southern California before he went to Princeton, where he did his undergraduate degree and excelled by every measure. He then came to Yale School of Medicine as a student when he was 22 and graduated from Yale, having again done exceptionally well, member of AOA, and was matched to return to where he grew, first few years of growing up, back to Durham, where he was, he joined a general surgical residency at Duke University. And during that time, he was not only fantastic clinically, but did important research opportunity had important research experiences in the labs of Bob Lefkowitz and Wally Koch, among others. I was very fortunate to get to know Michael at that time. I was kind of finishing or early faculty, and I always remember him as being the surgeon who you wanted to be on call with late at night. He was incredibly generous with his time, really quite compassionate, thoughtful, patient, and someone you want to be in the trenches with in the middle of the night when typically either the cardiac intensivist attending or the cardiology fellow was a senior physician, a medical physician in the hospital, and the surgeon on call, like him, was the senior surgeon in the hospital. And you know, I think it speaks a lot to how he was remembered, and I think I experienced this firsthand, and it really is just an honor to be able to present, to kind of share that with you and his family. He went. He met his wife, Dr. Halperin, at the time at Duke, where and they were married on the Duke campus, and then moved to Boston so that she can continue her training and he continue his training in cardiology, where he did cardiothoracic fellowships and a very unique at the time fellowship in interventional cardiology, working to develop kind of hybrid procedures, and joined the Brigham staff, you know, in 2006. So I did have the dates right. He was quickly moving up through the ranks and started a program in endovascular cardiac surgery. And until that fateful day in January of 2015, when a deranged patient murdered him, you know, on campus. So we're very fortunate to the family and friends of Dr. Davidson for providing the supporting funds for this lectureship, and very, very excited to introduce Yusuf, who will make some introductory comments about Rasha, who is a rock star and really a great tribute to Michael tonight. Thanks.
Thank you, Eric. I wanted to just say a couple of words to introduce Rasha. So it is, truly an honor for me to be able to introduce Dr. Rasha Alami. I've been fortunate enough to know Rasha for over 10 years now. I first met her when I was a junior cardiology fellow, and I count her as a true mentor and friend. At this stage of her career, she really doesn't need much of an introduction. She's a consultant interventional cardiologist at the Hammersmith Hospital in London. And for those that don't know, that's a premier teaching hospital in London. And she's a reader in cardiovascular sciences at Imperial College London. She's best known at this stage for being the PI and lead author of Orbiter and Orbiter 2 trials, which were published in The Lancet and the New England Journal, respectively. These are, two genuinely landmark trials in the field of interventional cardiology. And as well as being landmark trials for their results, they've really helped shape the way that we think about assessing procedural therapies for symptom-based endpoints, and have really shown the feasibility of being able to conduct placebo-controlled trials in interventional cardiology. So I think they're truly a landmark achievement. I just want to spend a minute or two to touch on some sort of non-clinical or academic aspects. From the moment I met Rasha, her, good humor, warmth, and humanity really, really shone through. And I was always struck by, the way she modeled absolutely exemplary behavior and the way she dealt with everyone. And that wasn't just professionally, that was personally, and it also didn't matter if she was dealing with people in positions of authority or not. And really, that's something I watched from an early stage in my career, and I have tried to model that and replicate it as best I can in my life and career. I think one of the best testaments I can give to Rasha's generosity of spirit is when Orbiter 2 was completed and accepted for publication in the New England Journal of Medicine, and a simultaneous late-breaking clinical trial presentation at AHA, she actually gave the first authorship to her PhD research fellow, who also presented that at the late-breaking trial sessions. And I think that type of leadership is really, really seldom seen in any field. So we want to thank her for being here, and it's really an honor to have her.
Thanks, Yusuf. I don't think it's fair to make me emotional and a bit weepy before giving a talk. I think that's a setup. So thank you so much for the opportunity to speak today. I'll just cancel that.
I got you.
Go on. Sorry, I'll ruin the Zoom. Perfect. So it's a pleasure to be here today. Thank you so much for inviting me, for providing the support to come and do this. It's a pleasure to do it in person and not on Zoom, and to have met so many members of the team today from all sorts of walks of the team. It really is a testament to Yale, the amount of research you're doing, the amount of really kind of pioneering clinical practice you're doing. And if there's any way that we can think about partnerships between Imperial and Yale in the future, from the fellows to the faculty to whatever, I'd love to help to facilitate. And I know that my colleagues would love to be part of it. So here are my disclosures. So I always start my grand rounds with a little bit about me, because I don't think you really need to see everything about papers and science. It's always good to hear something about the person who's speaking. So I was born decades ago in 1978 in Liverpool in the UK to two parents who came over as academics from Iraq. There is me, believe it or not, as a baby. And I went on to Oxford University to do my undergraduate, and then University College London. I'm an interventional cardiology consultant at Imperial. I have specialist interest in coronary intervention and intravascular imaging and physiology. And now I'm a clinical academic and a clinical trialist at Imperial. But I'm kind of an academic as an accident. And mostly because my PhD was something that led me to think about lots and lots of questions that I wanted to answer. And in doing my PhD, which was meant to really just be a stepping stone to a clinical career in London, perhaps with some kind of academic focus, I realized I loved academia. But importantly, the real side of me that I'm proud of is the other side. So I have a 12-year-old who spends most of his time watching or playing football. and a husband who spends most of his time watching or playing rugby. And so I try and do something in between all of that and also interventional cardiology. So now let's get on to the actual talk. So my talk today is a little bit about my research, but actually more about where I hope that my research will have an impact. And it's, I hope, beyond cardiovascular disease and more into thinking about clinical trial methodology. So I'm going to pitch to you that placebo is a very, very important part of clinical care. In fact, it's part of being a good doctor. Every time you see a patient in clinic and they say, do you know, I just feel better for seeing you today, you know you did a good job. And that is something that we teach our students and we hope to deliver from a healthcare system. But beyond the kind of mumbo jumbo to placebo, there's also some real science. So we know that red pills deliver more placebo than white pills, and that's been scientifically proven. That big pills deliver more placebo than small pills. The harder it is to swallow the pill, the more your pain relief from your osteoarthritis. And if any of you have origins in the Middle East like me, you will know that injections deliver more placebo than pills. Even if they're delivering exactly the same dose of paracetamol, the patient feels better. So now imagine what it's like to come to a cath lab or a surgical procedure, and we're all gowned up and we're ready for you, and you have your nice bed on the day ward, and there's a million people getting you ready and checklisting you for your procedure, and you see your handsome surgeon in their gown, and you are delivered the most placebo of all. And that's particularly important when you think of certain clinical trials. And those are clinical trials that test subjective endpoints. So endpoints like pain, weight loss, blood pressure, breathlessness, quality of life, things that different patients will report in a different way depending on the day, that more pessimistic patients might report more often than patients who just suck it up. It's different for different people. And these subjective endpoints are really impacted by what happened when you had your interaction with your medical care provider. So now let's think about a subjective endpoint and the therapeutic efficacy of any therapy, be it a tablet or a procedure. And I'm going to represent the therapeutic efficacy as this blue box. So obviously what we hope is that blue box is as big as we can possibly make it. And what we know from the blue box is that some of it will be the true physical effect of what we've done, a biological phenomenon, and some will be the placebo component. And for ease, I've said this is 50-50. But what we want to do as doctors is make that blue box as big as possible. And again, we can do that in two ways. We can be really, really good doctors, have really good interactions, reassure the patient, tell them the problem's fixed, deliver unblinded clinical trials or unblinded clinical practice, and that will maximize the size of the blue box by increasing the red part, the placebo. But we might believe that actually we want to do something more long-standing. We want to increase the physical component. And to do that, I would say that we want to find therapies with the greatest efficacy, or maybe select patients who have the most to gain. In the end, we've increased the size of the blue box, but perhaps this one has more longevity. So now let's bring it back to the topic of interest, kind of procedures, and ask the question, why don't we test more procedures with placebo control? So there's lots of barriers. The first is we worry about the patient. Are they ever going to agree to take part in these trials? We've got to tell them that there's a potential for a treatment without any benefit, and that will have potential risks. The physicians will have preconceived ideas of what a therapy might do, and they may not want to use these procedures, and they will believe that these trials are really complex. And of course, there's a professional interest that makes us think that's okay, we've got as much evidence as we need, and we can carry on doing what we're doing. We worry that the ethics committees won't agree to these trials. They'll say they're not ethical, we're exposing patients to harm. And of course, there's logistics. These trials aren't easy to do. There's also competing problems with funders because they know that these trials cost more money. And there's worries about feasibility. We know of lots of placebo-controlled trials that started and stopped early because they couldn't recruit. And again, many of our funders, be it industry or wherever they may come from, will have competing interests and might say, I'd like to do the trial that's easiest, enough to just get me to market. And then finally, our regulatory bodies are often told, well, there's no necessity to these trials. We just need to get these things into clinical practice. And there are obviously lobby groups and competing interests there. Now, you might have noticed that I'm trying to think about this wider space and trying to reframe how we think about these trials because I want to make them acceptable. And the first of these aspects, I think, is the terminology that we use. So you hear all the time about these trials being called sham-controlled trials. And as you might have noticed, I don't use those words. And that's because very early on, I noticed that patients do not like the word sham. Actually, many physicians, especially people who aren't in the clinical trial world, don't like the word sham. And if you look up the word sham, it tells you that something's bogus, that we're somehow tricking a patient, or that we're doing something that's actually deliberately false. If you look up the word placebo, you see something totally different, a very, very scientific description that describes trials that apply to both medicines and to procedures and surgical treatment. And so you can imagine if you're a patient and you Google your sham control trial or placebo control trial, how different it might be in terms of accepting them. So why should we choose placebo control to test procedures with subjective endpoints? Well, hopefully I've shown you that there's increased scientific validity, that actually we need to be able to quantify the physical effect of what we do and somehow quantify the placebo component. And that actually if we test procedures in this way, we might end up with some procedures not making it to market, and that might be good for the system in terms of financial impact. Importantly, there are disadvantages. You can potentially harm patients without any benefit. And of course, we've talked about all the complexities of trial design and ethical approval. But I think they need to become gold standard, or indeed the entry standard for procedures that are known to have a placebo effect to the endpoint of interest, when it's ethical to do it. And of course, there's some surgical procedures that just can't be tested in this way. And when potentially the procedure has short or long-term risks. So often I get asked, what about homeopathy? And I say, well, I don't really care if homeopathy only has a placebo effect, if the homeopathic treatment has absolutely no potential harm or risk. That's okay. But when you're doing a procedure that has harm associated with it, you need to test it adequately. And importantly, there are some trials that are impossible to do because you can't blind the patient and the medical teams. And maybe we can discuss that in the discussion. So I'm obviously not the first person who's ever thought about this. There are lots of people who've thought about this before. And in fact, when you look at systematic reviews of placebo-controlled interventions, you find there are lots of placebo-controlled trials in the literature. Interestingly, you might believe, well, there's probably an increased risk of complications. And actually, you see the increased risk of complications mostly occur in the treatment arm, not in the control arm. So it's the therapy that gives the risk rather than the placebo intervention. But also more importantly, and you're not meant to be able to read this slide, if you look at placebo-controlled trials across a vast array of medical specialities, you will see almost always that the effect size when that procedure is tested against placebo crosses the line of neutrality. You don't suddenly see the positive effect that you might want. And we've just recently accepted a meta-analysis looking at not only how placebo control impacts trials, but also which endpoints it really matters on. And what we've seen is that for endpoints like exercise-related endpoints, placebo has a massive impact to the difference between unblinded and blinded trial effect sizes. Whereas for things like recurrent bleeding, which is harder for a patient to report in a different way, it's a much more objective endpoint, you see no difference between the blinded and unblinded trial. So let's look back at some of the examples in the literature, and the first I'll talk to is renal denervation. We all know the story there. The unblinded trial showed big effect sizes in terms of blood pressure control. The first big blinded trial showed, in fact, that there was no difference between the placebo procedure and renal denervation, and that the blood pressure improvement was far smaller than expected. Outside of cardiovascular disease, if you look at osteoarthritis and knee arthroscopy, a similar story. The unblinded trial shows lots of pain relief in the patients who have knee arthroscopy. The first blinded trial shows neutrality between the two arms. And of course, in both of these examples, lots of people come along and start getting really upset because there's big business in there. Renal denervation is funded by so many companies. Lots of companies have been bought by bigger companies, and suddenly everyone's worried that this thing doesn't work. And I would argue one of the major issues with this field is that we often think about testing these procedures too late. They're already in clinical practice, we're using them, we've spent all the money, we've exposed the patients to harm, and now we're trying to backtrack. So now I'm going to come to my experience of the use of placebo control to test an interventional procedure. And this begins with a story in 1977, when the godfather of angioplasty obviously reported the first successful angioplasty. And that was in a young man who had angina and for whom balloon inflation in their LAD resulted in pain relief. And of course, as a result, it was published in The Lancet in 1978. And since then, there's been this vast evolution of angioplasty. Lots and lots of money placed into angioplasty and lots of angioplasty procedures across the world. And of course, interventional cardiologists like me being trained to do this procedure. A procedure that's taken off everywhere because it's relatively simple and because we thought it was effective. Now, importantly, we all know that in the vast majority of healthcare systems, angioplasty does work in saving lives and improving and reducing the risk of future myocardial infarction, but that's in the emergency space. And that's actually, luckily, the majority of the procedures we do. 2/3 of what we do is life-saving. But where we asked the question was in the elective space. Do we really know if angioplasty works? If someone comes to my clinic with chest pain on exertion and they have this really tight stenosis, do we know that fixing this stenosis works? Why do we stent this stenosis? And can we improve outcomes? So let's think about the outcomes first. So we might hope that fixing that stenosis will reduce their chance of cardiovascular death. It might reduce the chance of myocardial infarction, improve their LV function, improve symptoms and quality of life. And the first 3 of those groups are probably the endpoints we most want to impact. Unfortunately, we have lots of data that shows us we don't really have an impact. And before Orbiter, we'd had the Courage trial that showed us that angioplasty in this context did not improve outcomes. That led to lots of people being very upset and many people wondering about overuse of procedures. And of course, especially here in the States, people thinking about the business of healing hearts and whether we were doing too much and considering a procedure to be life-saving when in fact it wasn't. And the story is very obvious in terms of where we were then. We were probably overusing angioplasty because we believed it to be a prognostic procedure in stable disease. There probably was a slight overuse that needed to be corrected. But of course, lots of people were upset with the results, and many people spoke to the limitations of that trial. And many people spoke to the fact that a different trial was needed and the trial design needed to change. So then we had the ischemia trial, which tried to say, well, let's think about the issues with the original Courage trial, think about the potential of selection bias for the original patients, try and subselect a population of patients who might have the most to gain because they have more ischemia. And unfortunately, the results were very similar. Revascularization as a whole this time, PCI and CABG, didn't really have an impact on hard endpoints like we might have expected. So I'm going to grey out the cardiovascular death, myocardial infarction and LV function space, especially because we've now had another trial, the REVIVE trial, that shows us that even in ischemic cardiomyopathy, we don't seem to have as much impact as we thought. So let's come to symptoms and quality of life. And I would argue that symptoms and quality of life is a very good reason to think about a procedure or a therapy. It's no different to osteoarthritis with the orthopedic surgeons. They don't hope to save a life, but they hope to improve the patient's quality of life. So what's the problem with symptoms and quality of life? Well, the problem is how we assess it. It's very difficult because unfortunately there are many time points at which we might assess angina. And often it's assessed by us, but obviously often we rely on the patient report. And we will do these assessments at all sorts of stages, at primary care, in the ER, in our outpatient clinics, when they come for investigations, when they come for follow-up, and of course within our clinical trials. And there are many aspects of those various touch points that make angina assessment difficult and make it prone to the placebo component. The patient-reported factors are all here. We know there's language barriers and different patients will report things in different ways. Patients may understand their questions differently. When we ask them about pain, they often tell us it's tightness, and so on. We need to give them time to give their answers, but we often don't. And again, that has an impact on what they say. And every time we ask a patient the same question, they get coached, they change their answers, they start to think about things, they want to get the right response from their healthcare provider. And of course, if a patient has a preconceived belief of a treatment efficacy, they might want to make you feel better by telling you the procedure you did made them better. Thanks very much, doctor. You know, they want to help you. And then on our side, there are many of the same factors. And of course, for us as well, in the same way, if we have a preconceived belief that what we did should have worked, we might say, they still have chest pain, but it's likely to be atypical. I don't think it's their heart because what I did in the lab was fantastic. So how about the trials? Well, before our trials, we had lots of unblinded data. So the first of the big trials was the ACME trial, published way back in 1992. And here in the balloon angioplasty era, they showed that in patients with single vessel coronary artery disease, if you balloon their coronary artery, they were likely to have a significant improvement in exercise time, 96 seconds. They quantified the size of the blue box. It seems massive. Unfortunately, because it was an unblinded trial, you couldn't tell the difference between the green and the red segments. Who knows how big the physical or the placebo components were? All we had was overall treatment efficacy. And we got the same from ischemia, an unblinded trial telling us about angina relief in patients in the invasive arm. Once again, they quantified that blue box, but they didn't tell us how much of it was real or how much of it was physical and biological. And why do I think there's probably a placebo component to what we do? Well, it's in the evidence. We know that the unblinded effect size in our trials wanes off over time, and that something happens that means that the treatment effect with angioplasty wears off. And importantly, from the CTO space, and I know Yusuf's a CTO operator, when you tell patients that you failed at their CTO and you tell them it was an investment procedure, don't worry, when I bring you back, I'll be able to open up this artery, they have pain relief and quality of life improvement, even though their artery looks exactly the same. So there's clearly something we do, and we do it unknowingly. We do it with all the right intentions, but we deliver placebo. And again, we see that that angina relief wears off over time. What we also know is that in clinical trials, when we tell a patient we didn't stent them, you know, they were randomized to the control arm, they're much more likely to present with chest pain. And so there's a nocebo effect to telling someone you didn't fix the stenosis that you thought was really dangerous. So to answer lots of those questions that I asked before, I felt that angioplasty needed to be tested this way, and so did my PhD supervisors, because PCI isn't without risk, and because it's not universally successful. There is a continuum of treatment response, and to understand that and understand maybe which patients would benefit the most, we needed to be able to quantify the physical effect. But we weren't the first people to think about angina trials with placebo control. The surgeons did it first. And they did this trial of internal mammary ligation, which, believe it or not, used to be a procedure to improve angina. And unfortunately, when tested against placebo, it didn't work and it disappeared. None of our surgeons are ligating the mammary artery for angina relief. It was enough for everyone to say this wasn't an important procedure, it didn't work. And now we're going to come to my trials. So we tried in two trials to quantify the true physical effect of PCI. The first of those trials was Orbiter 1 and the second Orbiter 2. And Orbiter 1 was conducted on the background that existed at the time, which was that we were being told that for patients with stable angina, once they were optimized onto their anti-anginal medications, it was possible to do revascularization to improve symptoms if they were still symptomatic. Here's the design of the Orbiter trial, which I don't think I need to go into, but fundamentally it was the first blinded trial of its kind in patients with single vessel coronary artery disease. And I guess blinding was the key to Orbiter and the bit that I think will probably have its legacy, in that we did the blinding in the most rigorous way we could think of. And it was before the time that people really thought about how to blind patients, but it was based on, as I designed the trial, thinking we need to do as many steps of the procedure as possible that minimizes the amount of risk we expose, but actually mimics the procedure to the best we can be. So patients wore headphones, they were listening to music, they had a radial or femoral angiogram, they had physiological assessment, and then they were sedated to a deep level of conscious sedation before being randomized to having no stent put in, placebo procedure, or the stenting, and they were fast asleep. And when they left the ward, there was a standardized handover so that no one outside knew what they'd had done. They had totally standardized discharge summaries so that no one knew what they'd had done. The primary care physician was told they may or may not have had an angioplasty procedure today. Please treat them as if they've had a stent. We will tell you in 6 weeks what happened here today. And you might think, well, how the hell did we get ethics for this trial? So I thought the same when I went to the ethics committee, and I was absolutely sure that the ethics committee were going to shout me down. But believe it or not, they actually asked 3 questions. They genuinely asked, is it possible that we're implanting unnecessary stents? Does an angioplasty procedure have risks? And are there long-term complications to angioplasty? And I said yes to all of them. And then they said, and I don't make this up, so why has no one done this before? And then I just kind of innocently shrugged and waited for them to sign the line, and then we started the trial. So I often get people kind of be like, these patients can't have existed. Yusuf knows they existed because he did some of these procedures. And here's an example of one of our patients. And he's got his headphones on. He's unable to see the cath lab screen. He's got his music playing loud, and he's singing away to his music. And we always used to joke with Orbiter that they went from singing to snoring. And there was kind of this binary moment when they stopped singing and started snoring. So what happened? Well, I think we all know. We found, unbelievably, to all of us, and including me, that angioplasty did not improve the primary endpoint of exercise time more than a placebo procedure. We showed that the blue box was really quite small, and we quantified the size of that green box, and it was so much smaller than that 96 seconds that you'd seen before. But now I can talk about the downsides to doing a placebo-controlled trial and why anyone who's thinking about doing this in the future might need to think again. So some of the things that happen in academia, I just can't really believe, and maybe that's why I enjoy it now. So what I wasn't expecting, for the first time that I'm in a main arena presenting to all these great bigwigs and the unbelievable kind of godfathers of cardiology, and they really were really just godfathers in the room, I didn't believe that I was going to arrive at TCT and it was going to be the 40th anniversary of the first angioplasty. And that the whole of Denver TCT was full of birthday cakes and candles and cocktail parties, and everyone genuinely celebrating 4 decades of this amazing procedure. And what I knew was we were about to have this first page on the Lancet that said, doesn't work so well. And obviously what happened next is a kind of catalogue in my life. But all of a sudden you go from total obscurity, no one knowing who you are and not knowing how to spell your surname, to everyone wanting to interview me. And obviously everyone wondering, apparently there were lots of people who said, who is this man from the UK? And I kept turning up and they'd go, oh. And so, you know, it was an interesting time. This editorial didn't help me, calling for the last nail in the coffin for PCI. Not an editorial I'd written, not actually the summary of the trial in my mind. But of course, it was what lots of people spoke to and what I had to defend for a long time. Suddenly, there's lots of people really interested. They're saying that coronary stents are humbled again in stable coronary artery disease. This procedure's not working. And what you're not expecting when you're a PhD student from Imperial is to be in the New York Times and to be in the Wall Street Journal and to be in the Mail Online, one of the worst papers in the UK. That was an embarrassing moment for me. And, you know, to suddenly have Time magazine do an article about your work, that was not what I expected. What I also didn't expect was that the share price of the 2 major stent companies would suddenly drop, and that there was a Bloomberg alert that said this small trial from Imperial rocks the Minnesota stent companies. That was not good. And it also wasn't good that the lobby groups, Sky, came out and said that this was a horrendous trial that had been really poorly done. And, you know, these are people I respect, and it was really, really hard to receive some of that criticism. It was also really hard to have another editorial every week being written about the trial and to endlessly read about how you'd done it wrong. And of course, we came back, and I won't focus too much on that today, but we came back with lots of responses to, yes, some things we might have got wrong, but why we had to do it that way, because it was the first of its time. But also, where many, many criticisms were laid at our door, actually, they weren't really there. This was a small study. Well, actually, if you're improving symptoms and exercise time, you wouldn't expect that you'd need many patients to power that trial. You tell every one of your patients that they're going to feel better. People said, well, they're on far too many anti-anginal agents. Well, that's what the guidelines told us to do, so that's why we did it this way. And we tried to kind of come back. People said the follow-up was too short. And we said, well, actually, you would tell your patient that they're going to feel better as soon as they're back on their feet. You don't need to wait a year to feel better symptomatically from your angioplasty. You hope that they'll get back to tennis the week after. And so we argued and we came back, and I think many of you know my PhD supervisor, Daryl, who argued a bit more vigorously than me, or in a different style to me. But it was true, we were trying to argue back. So then we came with lots more secondary analyses. And in fact, I think they were much more interesting because the mean effect of the trial was the mean effect of the trial. But in fact, we started to see some interesting relationships. We started to see that actually angioplasty had worked. It had improved ischemia, and we could predict ischemia improvement based on how bad the severity of the stenosis was at the beginning. We also found that there was a subset of patients, 1 in 5 in the angioplasty arm, that became free from angina. There seemed to be a group of patients who had this super response. The very next day they felt better, whereas others did not. Interestingly, we started to find no relationship between ischemia and the ability of angioplasty to improve angina. And with invasive tests, but with the non-invasive test, we found actually if your stress echo was bad enough, you could predict that that patient was most likely to get some angina relief. And then we went on to look at some of their pulmonary exercise testing parameters, and again started to be able to see relationships between bad CPET scores and the ability to improve ischemia with angioplasty. But importantly, what we also saw was that the link between symptoms, stenosis, ischemia, which had been taught to us at medical school as being absolutely linear and totally straightforward, is maybe not as we expected. And there's lots of other things going on. So now we come to Orbiter 2. So of course, Orbiter 1 was tested on the basis of those guidelines. If you put patients on at least 2 anti-anginal agents and they remain symptomatic, then you're welcome to consider revascularization. The problem is that in most of our cath labs across the world, most patients have revascularization on 0 or 1 anti-anginal agent. We don't practice that in most of our labs. And that's probably for a variety of reasons, including the fact that those medications have a burden. So here's the differences between Orbiter 1 and Orbiter 2. This time, we enrolled both single and multi-vessel disease. We mandated ischemia for all stenoses, regardless of their severity, and we changed the endpoint. The endpoint was something really new. It was an angina symptom score, which encompassed many aspects of the patient's angina, but also some other significant features. The duration follow-up was slightly longer, 12 weeks. That was mainly just to make people feel better. We always had thought that 6 weeks was long enough. And the most important aspect was we thought, well, you know what? Since we've already upset the world, I remember going into Daryl's office and saying, I'm going to take everyone off their anti-anginal agents. And he said, no, you can't do that. And I said, yeah, we can. The renal denervation people did it. And taking someone off an antihypertensive is far more dangerous. That's a prognostic drug. They might have a stroke. Taking someone off their nitrate is like taking them off their paracetamol for their osteoarthritis. Why can't we do it? So we did. And we also thought about this new endpoint. We thought about the various angina scores, and I know you've got John Spertus coming to speak to you soon. But I think there were many limitations to the angina scores that they have. They've definitely got a role. But there's an issue that I'd seen from talking to our patients about recall bias. You know, sometimes the ones that are most symptomatic always remember their pain, or sometimes the people who just have that predisposition to notice their pain recall it in a different way. There's issues in terms of them changing their behavior. So the pain that I get when I walk to the shops is so unbearable, I've stopped walking to the shops. And so now I'm going to record that I'm angina-free on my questionnaire. But actually, it's just because you're not doing the thing that caused the pain. So the angina symptom score was modelled around the old-fashioned daily angina diaries, which was actually the original way that many of the questionnaires were validated. But with our Orbiter focus group, we were a bunch of patients from the original trial, we were able to decide about a new way of doing this, and we decided to do it using a digital app. And this app was really simple. Every single day, they were asked, did you have pain the day before? If they said yes, how many times and how severe? And importantly, they had a kind of FAQ, but they also had some weekly tester questions. So at the beginning, they set 2 activities that always cause their pain, a milder one and a more severe one. And each week, they were asked to do those activities to see whether they had their pain. But importantly, by taking them off their anti-anginal agents, we were able to test the effect of angioplasty unattenuated, without anything else that had had an effect on the response compared to placebo. And the design was really very, very similar to Orbiter 1, except that when they came in and once they'd done their symptom questionnaires, we stopped their anti-anginal agents unless they were taking them for another important reason. So a beta blocker for rate control for AF. That was continued and documented within the endpoint of the trial. They then had a symptom assessment phase, and in 2 weeks, they had to have episodes of symptoms to continue in the trial. If they were asymptomatic, they were taken out. They then came in for a pre-randomization visit where they had the questionnaires repeated, treadmill exercise time, stress echo, and then they were randomized in the cath lab again with much the same protocol as Orbiter 1. They then exited for 12 weeks, and they and their medical teams were blinded, and every single day of the trial, they reported their pain and then came back for a follow-up visit. And here's the endpoint that I think is important. So we wanted to deliver and to develop essentially a MACE or a combined endpoint for angina, because our patients said, actually, I know it's important to you that I have chest pain, but it's also important to me how many medications I take. That's also got an impact on my life, and the side effects of those medications are important. And of course, there were some high ride category events, so acute coronary syndrome, death, and unacceptable angina that resulted in angiography. And all of those various factors were encompassed in the daily score. And what happened in the score, and our statistician was amazing at helping us develop this, was that every single day for the entirety of the follow-up, they were given an angina symptom score, and obviously also in the run-up phase. And on that score, which was multiplexed, we could work out where they were in terms of their quality of life. So if they had increasing episodes of angina but no anti-anginal units, it went up. And as their anti-anginal units increased, it also went up. And importantly, they had access to the team 24/7. So if they needed anti-anginal medications by a pre-specified protocol, these were added in. And then finally, if they had those high ride events, then they scored the highest. So if someone had 2 episodes of angina on a single day, no anti-anginal units, a score of 2. If they had 3 anti-anginal units on a given day and only had 1 episode of angina, they were 22. And then finally, of course, if they had an ACS, they would score 78, and that score would continue for the entirety of the trial. So those high category events would actually saturate the score. And here's the endpoint result. So what we found was that patients in the PCI arm were far more likely to be free of angina and free of anti-anginal units. They had far less episodes of angina on any given day, but there was really no difference in terms of anti-anginal medication, no difference in terms of those adverse events. And importantly, PCI really improved that angina symptom score with an odds ratio of 2.2. So now to bring us back to that kind of placebo story, what we'd seen was you were far less likely to have angina. We'd quantified the blue box and we quantified the green box, which again was much bigger than the placebo component, shows us that this is a true physical effect. We did the same with exercise time. The blue box was there compared to placebo. The green box is this time much bigger than in Orbiter 1, probably akin to 1 anti-anginal agent. So, brilliant, Orbiter 2 worked. What happened next? Well, everyone said we'd saved interventional cardiology this time. I actually got called the savior of PCI in a conference, which was nice after being called the pariah of PCI. And the same lobby groups came out and said, this was brilliant, a fantastic trial, never seen anything like it. No one said it was too small. No one said the follow-up was too short. No one said that the patients weren't good enough. Everyone loved it. And they kind of confirmed something that I'd found years ago. I stole off someone else's slides. They confirmed a theory that I'd always believed from Orbiter 1, and now I had 2 arms of the paradigm. They confirm that actually when a new study comes out, everyone looks at the result. They decide if it's the result they liked and whether it validates what they already knew. If it does, fantastic. I'm not going to read beyond the abstract. If it doesn't, let's find some flaws. And you're always going to come to the same point, that you're a genius. So what were the real lessons from Orbiter beyond how we think about trials? So firstly, placebo is a really important part of what we do. The unblinded effect sizes are much larger than blinded ones, and that we need to do these kind of trials to be able to understand the placebo component. But it's important to remember that in a placebo-controlled trial, you don't totally quantify the placebo component, because you don't falsely tell them that they had angioplasty. You say it's 50-50. And so you probably deliver a kind of half placebo rather than the possibility that you trick them. And of course, it's unethical to tell a patient a lie. But what we did have now was the evidence from two pathways. And importantly, the other thing that was key was that residual symptoms were really common, about 60% in both trials. So where are we with stable disease? Well, we've got one pathway from Orbiter 1. You can put your patients on lots of anti-anginal agents. If they remain symptomatic, you can consider revascularization, but probably you won't get quite the bang for your buck that you're expecting. If you really want your bang for buck, you have to do it early and probably as a monotherapy. But I'm not now advocating everyone runs around and stents everything they see. I think everyone needs to think about how you choose between the pathways. Anti-anginal medication is a very reasonable upfront strategy, but of course it's got its own issues. It takes time and effort, there are side effects, and of course it may not work. But importantly, we've quantified the add-on effect of PCI as not as we expected. PCI is an anti-anginal procedure, has procedural risk, there's a cost, there's a dual antiplatelet therapy issue, and of course, we don't really know if the patient remains symptomatic if an anti-anginal agent on top afterwards will make any difference. So where do we go next? Well, the next thing that's coming out from the trial is the predictors. What I want to understand is how do we work out which patients we should offer an angioplasty procedure to up front? It's not going to be everyone. It will be a proportion of patients who will have the most benefit. And in EuroPCR, we're going to show the symptom stratified analysis. Is it possible that when they come to clinic with their symptoms, you can predict who will improve? And then we've got a whole bunch of trials that are all placebo-controlled, which you'll see over the coming years. The first is Orbiter Star, which is a trial that actually thinks about the pain and the pain characteristics and how that might predict treatment response. So this was based on the theory that when you're in a lab and you have a stenosis like this, and you stent the stenosis, often a patient will tell you, I've got pain. And for us interventionists, we all know what it's like. You say, is that your angina? And they say, yeah, absolutely. That's exactly what I get at home. And you think, phew. And then however, if they say, no, I've never had that before, you think, oh, I need to retract the stent. How do I is there a vacuum pump? How am I going to make this better? You're really upset when they say that. So in the STAR trial, we tried to do exactly this, balloon occlude an artery and see how similar the pain was to what they got at home and see if that predicted response. And my fellow Chris Rajkumar will present that at EuroPCR. The Orbiter Cosmic trial thinks about a new procedure, the coronary sinus reducer, which is purported to improve angina in patients with refractory chest pain with multivessel disease and no options for treatment. And in this placebo-controlled trial, what we're trying to do is say, what's the placebo-controlled mechanism of action of the reducer, and does it actually improve angina? And we're going to present this, and my fellow Mike Foley will present it at ACC with a simultaneous publication then. The next trial is looking at physiology. So we're always told physiology in the lab is a fantastic way to guide treatment response. And we're told that FFR thresholds of 0.8 should be used as treatment thresholds, but that if you want to detect ischemia, 0.75 is probably better. However, with all of that, people tell us that's probably also around the place at which people have angina. But if you look at the evidence, no one's ever shown that. No one's ever shown a relationship between those cut points and pain. And it's probably possible, and I think we're heading that direction, that different patients have different thresholds. And why should my FFR cause my pain at the same threshold as someone else in this room? So in Orbiter Fire, we're taking patients and we're exercising them in the lab, and we're trying to work out whether or not with placebo-controlled inflations to varying degrees of FFR, we can predict pain. And we're building on that with a study called Orbiter Moon, which is actually a multi-vessel assessment of pain. And you can see one of our experiments here, and this is the kind of thing we do at Imperial. So cath lab, bike, patient blinded, all sorts of things happening, balloons being inflated, etc. as we try and model this. We usually have about 100 medical students in the room holding different bits of kit. And they, you know, the cath lab team get quite disappointed when they know the case is on the table because they can take hours, but our patients are fantastic. So I'm coming towards the end, I promise. So why do we need placebo-controlled trials and medical procedures? Because placebo is a really important and valuable part of medical care. That medical procedures are not without risk, that we have to quantify physical effects, and that blinded effect sizes are usually smaller than the unblinded equivalents. And that blinded data might help us actually stratify therapies to the right patients. So I hope that in time, all those people that I said, all the various lobby groups, etc., who have been resistant to these trials, start to think about this as entry standard for medical procedures with subjective endpoints. So importantly, as I come to the end, you don't do these trials on your own, obviously. And there's a whole million people who run around doing it with me. And these are photos of various members of our team. At the end of Orbiter 2, we were in Philadelphia and we all went and ran up the rocky steps. And it was quite a moment, actually, after all the angst that I'd had over the years before. And it had been quite lonely in those years before. So now it's fantastic to have this amazing team. It's also really important to have my husband and son. And this is a day when we were in Barcelona and I was giving a talk. And they'd come with me. He used to come with me a lot, my husband, because he knew I'd be like in tears at the end of the day. And so at the end of the day, I went to find them and they were on a tandem bike. And I said, have you seen the name of the bike? And it was the Orbiter bike. And my husband had not spotted the name. I was like, have you seen what you've done? So I had to take the photo. And then without any prompting, my husband, I reckon, is the general cardiologist who loved the result. And my son was the interventional cardiologist who was hiding his head in his coat. Also, you can't do these trials without the patients. As you guys probably know, every single trial we ever publish, we publish every single angiogram from every patient. And you just see their angiograms. You know them as this. They're actually real patients and they're amazing. One of the things we didn't do well in Orbiter 1, and I always think this when I see this patient photo, is we were not very good at thinking about diversity. And in Orbiter 2, we've got our patient evening in a month. We've really put in more effort. Because I think the problem with some of these trials is they're really complicated and they're far easier to explain to your educated white man. But we need to get better at working out how we explain them to a wider group of patients. And importantly, when you do these trials, lots of people say, how patients can't agree to this, they must hate it. They love it. And this is an example of a patient who every single day for the entirety of Orbiter 1 sent me a text telling me, good morning, happy Christmas, how was your day, etc. And if he didn't send me a message, I thought there's something happened. So the patients are so valuable to this. They actually really enjoy being part of it. They are looked after very, very well. And in fact, we've in both trials recruited over 50% of the patients who were eligible. So it is possible to do these trials. And I'll stop there. I'm sorry, I've spoken for a long time.
Roger, John has a question. Maybe he should have muted himself and asked the first question. John?
Yeah, no, it was a wonderful talk. Thank you so much. The power of placebo is an amazing thing. And you've obviously thought a tremendous amount about this, but given how impactful a placebo by itself is, if you're offering a procedure that has an impact plus its placebo impact, does it make sense to negate the placebo impact? Because we know placebo makes patients better, and what you in essence are doing is not allowing them to have that. And so how do you think about that? It's something that I don't know how to process. I'm curious how you think about that.
So I think of it in two ways. I don't think it's ethical to offer a procedure if it's entirely placebo, right? We're not going to bring patients in for the radial angiogram and then say, we fixed you today. That's going to be very, very hard to do. It's okay if it's homeopathy, but it's not really okay if it's a procedure. But where I do think it's important is when you've proven a physical effect that's significant, so it's worth doing the procedure, there is an ability to then increase the treatment effect by enhancing placebo. Just be a good doctor, reassure them, tell them you fixed the problem. And we do that all the time, I think, to some extent in cardiac rehab and with our outpatient clinics. We reinforce what we did. And that's, I think, okay if you've already proven that there's enough of a physical effect to make it worth it. I hope that answers.
I may have missed this part, but I don't think you excluded the patient with diabetes, right? And then you went to angina. And so you kind of, you added a layer of the complexity to it because a lot of patients with diabetes don't have angina,
Yeah.
shortness of breath. Then you're comparing this study to the previous one, which I think there was 8 6 duration, which you can stop if you're short of breath. So can you tell me that?
Yeah.
How
So-
how was the result in diabetic patients versus non-diabetic?
Yeah, so diabetes was included just as any other risk factor, and there was a decent proportion of diabetics in both trials. Importantly, you're right, diabetic patients may be asymptomatic, but what I would argue in response to that is if the procedure is there to improve their symptoms and doesn't have a prognostic benefit, then we shouldn't be doing it even in the diabetics because we're not going to make them better from asymptomatic. The question about... Yeah, so the question about breathlessness is really interesting. And I know the answer to this, but can't give it to you. Because at PCR, we're going to talk about that. We're going to talk about which symptom characteristics predict symptom response. And one of the questionnaires in particular really focuses on aspects such as breathlessness. And is breathlessness a surrogate marker for angina? We're going to show you soon. Yeah.
Brilliant talk. What a creative, visionary person, and the execution is just amazing. I have a question. So the angioplasty went after you, but why didn't the non-invasive testers who were quantifying the amount of ischemia go after you? Because when you look at the entire body of work, doesn't it say that we shouldn't be evaluating for quantification of ischemia?
Yeah.
I know the answer to that because they went after me.
Yeah. And they went after the ischemia trial, and that kind of shielded me. No, you're absolutely right. So we, again, looking at many of the bits of data we've looked at, we've shown that the ischemia link with symptoms is poor. And with disease.
In the United States, more than half of the revenue for cardiology practices come from quantification of the amount of ischemia.
So there are a number of aspects of this that I think are really important. Ischemia tests, I am no longer really sure of their value, especially if they also don't predict prognosis. And the other aspect that I think is, it's been proven by other people, not me, but when we were doing Orbiter, routine ischemia testing was still practice. I think it's less so now, but the ability that you might put someone on a treadmill exercise test who's asymptomatic and that might trigger the need for a procedure, I think we've shown that's not true. And again, I don't want to point to more data, but we're going to see data soon about symptoms. And I think it's possible that we need to stop imagining that all of these markers are truly linked to symptoms. We believed that they were tight surrogate markers, but they probably aren't.
Phenomenal talk, and thank you for your leadership in the field. It's really inspiring. I want to hear more about your sense of the FFR. I'm not an interventional cardiologist, but I always ask the question. We have these cut points. Everyone's feeling very good about them, but we don't really know. If someone has an E of 38 versus one, or if they're, and you made a comment that at different FFR, people may have different symptoms and may have different outcomes.
Yeah.
Can you speak more about that data?
Yeah. So I'm actually a real physiology proponent. I use it in the lab all the time. But the way I used to use it was as a treatment binary cut point for me, right? It told me treat or don't treat. Now I don't use it like that. I use it to tell me about distribution of disease. And my feeling is when I have diffuse disease, the chance of me being able to fix anything is unlikely. Is it better if they have a graft? Maybe, but we don't know. If it's focal disease, and I didn't show you this, showed that from one of the Orbiter studies, we were more likely to see improvement in terms of ischemia, not symptoms, but ischemia. So I think if we repeated ischemia again, arguably maybe, other trials, and we took out patients with diffuse disease and we didn't enter them into the trial, they were not there because revascularization couldn't help them, you wonder if things would be different. Because it's not possible to me to believe that stenting for multiple millimeters in a coronary artery and having very little increment in your physiology is going to improve your pain. But I think the physiology world also needs to wake up, much in the same way as the non-invasive space. Invasive physiology is probably not doing exactly what we expected. And there are no physiology trials that show that FR or IFR improve cardiovascular death or MI. They reduce your chance of unplanned revascularization, but that's an unblinded endpoint in unblinded a very subjective endpoint in unblinded trials. So I feel like I sound like I'm out there to get every possible field in cardiology. I'm not, but I do think there's a lot of work there as well.
Thank you. So what do you make of the reduction in spontaneous mitral infarction in the ischemia study? So you're talking about angina.
Yeah.
There is evidence out there in our guidelines, or actually, if you go down the state 1 syndrome guidelines, there's a full arm of our guidelines that talks about movement process, then mitral infarction, etc. So how about that?
So I think the spontaneous MI story is obviously very interesting, predominantly all from the ischemia trial. We didn't see that from Courage. It's balanced by procedural MI risk, and we can kind of argue about which one's more prognostic and sort of talk to that. The long-term data from ischemia will be important. I do think, I grade out myocardial infarction as an outcome. I think there probably are patients for whom we can improve MI rates, but I don't think it's everyone. And I don't think it's predicted by how tight their stenosis is. And we've seen that already from the prospect data, that often it's the milder stuff that causes the spontaneous MI. So maybe what's the truth of this is when you've got a very high atherosclerotic burden, you've got a higher risk of spontaneous MI. And what we need to kind of work out is if there's anything else about the plaques. Are they more vulnerable? What is it that predicts spontaneous MI? But I don't think stenting everyone's proximal LAD reduces spontaneous MI. There'll be a proportion of patients that it does that for, but it's clearly not a big enough effect to have driven cardiovascular death changes or to have overcome the peri-procedural MI issue that we saw in ischemia. I don't know. The studies are coming, I think. Maybe PCSK9 inhibitors, I don't know, right? But maybe something else to their therapy, yeah.
Sorry for another question.
Yeah.
You're in the era of precision medicine, and we have individuals who have premature coronary artery disease, and we don't know how the response of them is going to be compared to the general population. Are you going to incorporate that into the study?
Yeah, no, we haven't ever looked to that, we've not looked at premature coronary disease. We haven't looked at whether those subsets of patients will be different, and we haven't recruited, those subsets of patients. So I don't know. I suspect that they're not so when you look at the data on angina, what you see is the longer they have their disease for and the more disease they have, the more their angina actually goes away over time. They get ischemically preconditioned, they, different things, they have collaterals that form, etc. But whether those patients are more likely to have MIs, as we were talking about, I don't know, maybe, but I can't answer that.
We have a lot of South Asian population.
Yeah. So, to the other side, it's not the answer to this question. Should we put statins in the water? Yeah, probably. But should we stent them all? No, because, why is metalwork going to change the progression of their disease?
So it's past the hour. I want
Thank
to
you.
make one comment, just to highlight what amplifies what you said, which is how valued the patients and how much perhaps better they became being part of a clinical trial. So it's my opportunity to remind our faculty that we should put every patient we can into a clinical trial. And if we don't have one, we should do what you did.
Yeah, make one.
With that, I really want to appreciate
Thank you.
Thank you for your great talk.
Thanks.
So,